everyone, and thank you for all of those people who are also driving home and still being connected. That's fantastic. We've got, as Kylie said, we've got quite a full agenda and mainly case studies, which I'm really pleased.
I haven't had a chance to talk to you yet. So anyway, I will.
Sorry,
yeah.
and I can hear you.
Yeah, we can hear you.
Oh,
no, she's done it. Yep.
Oh, okay. Sorry, I thought that somebody couldn't hear me. Case studies from Bendigo Health, from the Loddon Valley area, and they're going to be really interesting, I'm sure. But first of all, we're going to do a little bit of a snapshot from 1-800-MY-OPTIONS, letting us know what's happening in the time of COVID, and we'll finish up after the presentations. I'll try to keep people to time. Last 10 minutes where anybody might want to share or provide an update on their service. Okay, so over to you, Carolyn, from 1-800.
Thanks, Patty, and thanks, Kylie, and thanks everyone for having us here. First of all, slightly exciting news is that we'll be getting to our 10,000th caller next week, which is pretty extraordinary. Yeah, in just over 2 years of service. So thanks to everyone who's in this meeting, as well as all the other partners that we have. We will be doing a little bit more official announcements, and I probably actually, now that I think of it, wasn't really meant to say that right now, but I'm telling you all anyway because you're awesome.
Mum's the word.
Will there be cake? Will there be cake?
Ah, virtual cake perhaps? So we've been looking a little bit at the snapshot of our callers, and particularly I think the really interesting thing is that we've had some differences in callers in the last few months that are showing up in our stats. So generally we get around 12.5% of our callers are rural. At the moment it's down slightly, it's down about 0.5%. Maybe not that significant, but it is something that we've been noticing definitely from the phone line. Interestingly, the areas that we are getting fewer calls from rurally, I think the most significant one is Gippsland. We've really had a significant drop in callers from the Gippsland region. Had a lot more from Barwon Southwest as well, and I'm not really sure exactly what's going on with the increased number from Barwon Southwest and a decrease from Gippsland, but that's what's happening. We're also getting slightly more younger callers, so generally around 4% or so of our callers are under 18. Oh no, sorry, normally about 2.5%, but it's now gone up to about 4% of our callers being under 18. And again, we're getting slightly more callers that are 18 to 25. Again, we don't really know what's going on with that, but I think it's an interesting trend that we've been seeing in the last few months. And another thing that we've been saying a little bit lately is that gestation is tending to be presenting a little bit later. So we are getting more people presenting at over 18 weeks gestation, as well as those between 12 to 18 weeks had a slight increase in that as well. And I think a lot of women are saying that that's just because they've been a little bit nervous or just had too many things on their plate to get organised to give us a call at the moment. Help seeking's been a little bit more difficult.
Sorry, I was talking to myself again. Thank you, Carolyn. We've had a similar experience with not seeing the same numbers from Gippsland. But nor are we hearing any tragic stories of obstruction and then a really late call. So I really haven't explained that yet. We wondered if we might be getting, you know, at this point in the pandemic, we might be seeing some really delayed cases, but we haven't from Gippsland. But we are seeing a greater proportion of greater than 18 weeks. So our clinics are as busy, if not slightly busier than ever, but with a preponderance in the late gestational age, which would be what we would expect given that other providers in that gestational age may be a bit more limited because of the pandemic than we are. Yeah,
I agree with that. I think the Gippsland case is particularly concerning because there are so few services out there that we at least are aware of. And if we're not aware of them, I think sometimes you could surmise that it's a bit more difficult for women to access them if they're not out in the open. So we are keeping a little bit of an eye on Gippsland and trying to figure out what's going on there, but there isn't really anything particularly evident out there.
Does anybody else want to comment or ask anything of Carolyn? I guess I just wanted to say yet again, your team and the existence of 1-800-MY-OPTIONS has proven to be our really good source of data with regard to how things shift and change and respond to funding or lack of funding and new services opening. So it's really useful.
Well, we wouldn't be able to do it without everyone else who's in this meeting as well. So thanks to everyone for helping us so much in our success.
Anyone else want to comment? So I'm just looking at the next item on the agenda. We've got Simone here. We have got Simone. Hello, Simone. I saw you before. Yeah. So Simone's case study number 1. Surgical abortion care in a rural public hospital. We're really interested to hear from you, Simone.
Sorry, I'm trying to work out Zoom on an iPad because my computer wasn't letting me log in, so apologies. So I'm just going to my computer now to bring up the case study. Sorry, I had originally planned to talk about our experience with telehealth. We had been doing telephone consultations, and then I got told 2 weeks ago that we were going onto a virtual platform, but it hasn't happened. So I'll have to talk about a woman I saw yesterday, and Lou Holland also had experience with this woman. She referred her to me for a surgical abortion. So sort of, well, it's probably worth noting that we still don't have a virtual option for it. But this woman, I thought, probably encapsulated a lot of the experience that we've had of late. So she was an 18-year-old woman wishing for stop. She was probably heading towards late for us. She was 11 plus 5 weeks. So we, had to see her, had to facilitate it. So she had an intellectual disability, and she presented with her partner, Ty, who was also 18. And he didn't have an intellectual disability. She was G2P1. So her first baby is not in her care, in DHS care. She was quite interesting to talk to because she was quite childlike. She was able to give consent. She's on NDIS package. Just looking through her notes. She lives with an old carer, still that she knew from residential care. So yeah, getting access for her, I think, was important. I think even in a virtual space, it sort of made me think, oh, I wonder how I would have gone with in a virtual space with her. And I think it really still needed that face-to-face interaction. So I think that's probably a point, sort of from my perspective. I've used virtual health in other clinics that I'm in, but I think for this one, we still need capacity to be able to see some women face-to-face. Lou, you might have a comment about this one too, seeing she saw you.
Last time you did study 2 teleconferences, you slept on the couch.
Oh, sorry, that's difficult to hear.
That again, Patty.
Lou, we just missed your comment.
Hello, everybody. Can you hear me? I didn't actually comment. I'll comment now. I suppose the 2 issues that I have is that I had previous experience with this young woman when she was pregnant for the first time, and she had no support from the partner in the pregnancy, which is her current partner, because she had an IVO against him because of her aggressive behaviour. And throughout her pregnancy care, when we were discussing options for her, there was just no way that she wasn't going to continue the pregnancy. So subsequently, she came into my clinic because she was referred by one of our GP registrars to talk about the maternal screening tests that she would have been eligible for, because he was under the impression that she was continuing the pregnancy. So when I saw her for the first time, it was the first time she'd actually said that she had chosen to end this pregnancy. And because I knew of her intellectual intellectual disability and her cognitive deficit, I was really concerned because he was in the room with her. He and his mother have guardianship of their 5-month-old daughter. And I was really concerned about how you assess reproductive coercion of a young woman who's with this partner who won't say anything without him actually agreeing. So it took us a long time to actually get through the nuts and bolts, and repeatedly posing different questions and scenarios to the young woman to elicit whether or not she was really sure that she wanted to go down the track of having an abortion this time. So had that been in a room where we were doing telehealth and I wasn't able to see the interaction or the non-verbal communication between her and him, I would have been a lot more concerned. So I was fairly confident in my assessment with her, but also my previous knowledge of her. Because of the situation in our clinic room, we could only have 2 people in the room. So her carer, which is a woman who's a young adult who's a friend who used to be her actual residential carer worker but is now not working in that organisation, couldn't come into the room. So it was a discussion of whether he had to go out and I had to bring in a 3rd person. So it was just an interesting scenario for us in regards to how we have to think laterally in this time.
So Lou, was she reluctant to be seen on her own? Was that the other thing you were saying?
Yes, she refused to be seen on her own. She wouldn't come into the room. So
That was the same experience at Bendigo Health. She completely refused to be seen without him and said she threatened to walk out on us.
So can you tell us, so it was a fascinating case and very, very challenging. Can you tell us what strategies you used to try to ascertain if she was actually being coerced?
Well, from my point of view, because I had a previous knowledge and understanding of her cognitive capacity, and also previous knowledge of her involvement with the legal situation in regards to when she becomes confused with how you try and discuss situations with her. Her first, I suppose, reaction is to become aggressive. So I was really, so she'd yell and say, "Stop, I don't want to talk about that," or "Stop, that's not going to happen." So there was that real kind of black and white cognitive thinking. So I had to kind of go on having a talk about how she managed after she had her first baby, what happened, where she was living, and just within 3 or 4 days before she came into my clinic, she had been living with her biological mother. So the young woman had been living with her biological mother who was going to care for her during the pregnancy. But she was removed from her mother's care, even though she's 18, but she was removed from that house due to violence. So we really didn't have time to explore that, but she was in a safe place herself with this 3rd person who was understanding of her history in terms of her significant mental health, her anger issues, and now her pregnancy. So we were able to just talk about the positives of her being able to, in the very near future, to see her daughter. So due to COVID, she wasn't actually allowed to see her 4 or 5-month-old baby. She wasn't visiting the house where the baby was with her partner and his mother, and she was really keen to re-engage with supervised visits with the baby. So she was able to articulate that her life wouldn't get any better if she had another baby. It would be the same pathway, and she said, and I may not ever be able to see, well, she used her baby's name, I may not ever be able to see my baby again. So that was I was fairly confident that she understood that kind of emotional kind of interaction of what's happened. Yeah.
And probably of note from Bendigo Health's perspective is I had a quick flick through her medical file before I brought her into the room, obviously, and she has had multiple presentations to our emergency department in the last 12 months with attempted self-harm, suicide attempts. So that, and also we had multiple legal documents on her around issues that had occurred in birth suite with the birth of her first baby. So bearing in mind Lou's picture and then the knowledge of a very delicate psychiatric history, it was quite tricky. And it's similar assessment to Lou, but I was probably more keen. I didn't want to make her hostile, so I didn't probably do as comprehensive as what Lou had done. And she'd said to me, she said, "Oh, I've already talked about this," and got quite agitated. So I took that as a sign that it had been discussed.
That's a really nice example of you and Lou working as a team, though, isn't it? You know, that there were two opportunities to engage this woman, and maybe the way I'm thinking about it when I listen to you is that you were improving her ability to consent by creating an environment where she felt more comfortable, rather than making a blanket statement about whether or not she had capacity at that point. You were improving her capacity by the way that you approached it. So I think there's a really nice learning there. What was the outcome, Simone?
She's booked to have a surgical termination on Friday, and I'm fairly confident she will go ahead with it.
Do you think there were any kind of things that needed to be put around her care to support her on the day? Anything that you wanted to share with us?
Ironically, she was adamant that she must have him in for the sort of pre-abortion care. I explained that that's not appropriate for, the post-probably abortion care, like when she comes out of theatre and all that sort of stuff. But she was quite adamant around that he be very present.
In the waiting area while she was
yeah, and we've got, like everyone, tight restrictions. So it was just sort of notes around that.
And is that likely to happen? Because we've had a couple of instances where our COVID guidelines definitely butt up against compassionate management of cases sometimes. Is that likely to be able to be facilitated at your place?
I'm hoping, but I can't comment because day surgery is completely outside, my remit. In women's, we would make it happen, I think.
They're a world of their own, aren't they? Does anybody else want to comment on this case? Because I think it brings a lot of things to the fore. Not least of them the fact that in a smaller community you have probably a much greater chance of having met the patient before or knowing their family or something. Would you agree, Lou? You're nodding there. You might have looked after her mother or something,
I think one of the advantages of how our service is, and I know Marianne's listening in here, so hi Marianne, is that we also have a really good connection with the services who potentially work with women who do have cognitive deficits, or the agencies who work with mothers whose babies have been removed from their care. So we also have that trust from those agencies that when a young woman might be reticent of coming in to talk about options for an unintended or a pregnancy, is that we do get that buy-in from those agencies to, that it's a trusted service. And I think that's really important too, which, so you get that kind of lateral trust, which is, important. I just want to put aside when we talked about contraception, of course, with her, it was just a nightmare from a potential point of view. So this young woman wouldn't even have a blood test. So one of the ways that I could kind of work out that she was determined to go ahead with this procedure was that she agreed to have blood tests done, regardless that she'd had a baby, 5 months ago. But when we talked about long-acting reversible contraceptions, we just couldn't get any headway. I had done extensive education and results showing and pros and cons, and all she said is that she will only take the pill, but she says, I know I forget it all the time. So that's the next challenge, and I would love some strategies.
Lou, I got her to consent. I consented her for an Implanon.
That is marvellous.
Does anybody else want to comment?
Just to
no.
say thank you for sharing the story.
Yes, that was from Nicole. Yeah?
Yeah, that's right. And yes, it is challenging in small communities where you do know the people, and the onus of getting those decisions right feels even heavier.
So we might move on to Mark. Are you there? Mark and Elise?
Yes, we're here, I think.
Hi.
Elise's slides are first up, so she's
Yeah. So
talked
over to you first, Elise.
I'll just share my screen.
Hi, Elise.
Hello.
That is Nicole, isn't it?
It is, yeah.
Yeah, it's me. Yeah.
Because you've got Kevin Casey. We can see you're not Kevin Casey.
Sorry. Yeah, that's my husband. I don't know.
So can everyone see that screen?
Yes.
Fantastic.
Beautiful. Okay, thank you, Simone and Lou. That was a great case study. So my name's Elise Corman. I'm the Women's Health Nurse at Women's Health Loddon Mallee, and I'm going to talk to you about our Choices Clinic using a shared model of care. Now it's not letting me click through the slides.
How can we help her?
No, she's got the screen.
There we go. Okay, so Women's Health Loddon Mallee services an area with a population of over 320,000. 165,000 women live in the region. Almost a fifth of the population is born overseas, and the region is diverse in language, culture and religion. And our purpose at Women's Health Loddon Mallee is the health, wellbeing and equity of the Loddon Mallee women. So our Well Women's Clinic, the services that we would normally provide are listed there prior to COVID, but during COVID, our main focus has been around unplanned pregnancy, choices counselling, termination of pregnancy referral and assistance with pathway, also STI testing, and just information around sexual and reproductive health, especially around contraception advice and referral. So during the COVID-19 pandemic, our Well Women's Clinic has continued to operate 3 days per week. The clinic is run by our women's health nurse, that's myself, and due to restrictions, consultations have been via telephone or telehealth, and phone interpreters have been used as required. This year, before restrictions were put in place, Women's Health Loddon Mallee had been changing to a new clinic system, Clinico, where all our notes are. This was fortunate timing, as this new digital system has been a great tool in keeping the clinic running smoothly. Clinico facilitates effective communication between clients and other service providers. So a shared model of care is used to provide termination of pregnancy services. So this was developed in April 2019. An MOU was developed and partnerships between Women's Health Loddon Mallee and Castlemaine GPs Mark Farusha and Richard Mays. So women requesting a termination of pregnancy are seen in a timely manner. Referrals to Women's Health Loddon Mallee come from GPs, Bendigo Health, 1800 My Options, or women self-refer. So over 60 women have accessed the shared model of care in 12 months. So approximately 50 women have accessed a medical termination of pregnancy, and approximately 12 have access to surgical termination of pregnancy. And these numbers have grown since these slides have been put together. So talking about the process of accessing a termination through the shared model of care. So after a woman contacts Women's Health Lord and Mallee regarding an unplanned pregnancy, options counselling appointment is made with the nurse. Nurse consultation is via telehealth or phone call during COVID-19, and the appointments are usually 30 to 45 minutes. Confirmation of pregnancy is done at home during COVID, and pregnancy choices counselling is provided, and it's providing a non-judgmental safe space for the women where they feel listened to. So we have a discussion regarding contraception, recommending LARC, discussion to screen for sexual assault and domestic violence to ensure service is responsive to the client's needs. A detailed history and assessment is taken, and all testing is organised by the nurse, so pathology and STI testing, and the pregnancy dating ultrasound, which can be done here in Bendigo or in the GP's room. Education is provided regarding the procedure, return appointments, pharmacy options, and also post-termination counselling. So I'll just share with you how the model has been successful. So if a client decides on a MTOP, an appointment will be made with the nurse, made by the nurse, sorry, with Mark or Richard in Castlemaine. The client will be seen by the GP within the 24 to 48 hours in Castlemaine or via telehealth. The Women's Health nurse and the GP communicate via a family planning shared live database, which Mark created, and it's also the appointments followed up with a detailed referral that is sent through to the GP, and we usually always follow up with a phone call as well. And we are always get verbal consent is obtained from the woman to share information with providers. So if the pregnancy dating ultrasound is conducted by Mark or Richard, there is no charge and the medication can be provided at the same appointment. So during COVID-19, the processes required to ensure a timely termination have been streamlined through a digital contact system. This has been made possible through the shared care model. And that has been our aim, that the model is streamlined and uncomplicated for the women. So our key findings during COVID-19, 80% of the women have chosen an MTOP after receiving appropriate counselling. Most women are not using effective contraception at the time of unintended pregnancy. Social media messages are important regarding access to services, availability and support, and 1-800-MY-OPTIONS and Family Planning have shared some great social media messages which we have also shared. So that messaging around abortion being essential is crucial. Importance of screening for domestic violence, sexual assault and reproductive coercion to ensure appropriate referral and support. So continuing with key findings, there has been reported incidents of rural women accessing services at later gestation, resulting in a stop in Melbourne rather than regional care. Cases where a stop was not the client's preference, but GPs in small towns have not acted in a timely manner where a medical termination of pregnancy could have been accessed with the initial appointment. Also increased stress and anxiety for women during these challenging times of uncertainty with access to termination. And women have required referral for further counselling and ongoing support as a result of experiencing a more stressful and traumatic experience, having a surgical termination of pregnancy, creating greater travel, increased cost in later gestation. So the reasons for termination, I would say they're very similar to pre-COVID. However, additional reasons created by COVID-19, I would say greater uncertainty about the future and recent change of circumstances. And these barriers, again, are very similar, but additional reasons created by COVID-19 are lack of privacy due to family members being at home and increased opportunity for coercion. Also, additional caring responsibilities and, of course, restrictions during isolation. So women have contacted our service from all across the Loddon Mallee, including Mildura, Kerrang, Donald, Swan Hill, Echuca, Rochester and Warwick Nabil, also Horsham. But with unplanned pregnancy counselling, they also can receive that at Bendigo Community Health, which you've heard from Lou tonight, and we also access STOP and medical termination of pregnancy from these listed organisations, and often with a woman that needs a surgical and her BMI is over the 40, we're referring back to Bendigo Health. And that is me. Now Mark's turn. Thank you for listening.
Okay, I'll just try and share my screen because I inadvertently didn't send my slides through. Not sure if that is coming through, but I can just speak to my slides. So as you can probably tell, that once the women get to me, there's not a whole lot left to do because Elise has done such a great job. And I think from the GP perspective regarding the collaboration, it's been just awesome. And we've got and the reason it's been so great is just open communication. Elise will often text either Richard or myself or give us a call, and we're reasonably accessible. We might have to squeeze in between patients, so it might be 5 or 10 minutes after she's initially made contact. And then either ourselves, Rich or myself, would make the bookings or get reception staff to bring the patient within the next 24, or bring the patient that day to get them in the next 24, 48 hours. And so we generally give them a call on the day to let them know, or at least actually lets them know that what time the appointment is made for. We initially, when we got started, we had the blood slips and ultrasound request slips organised. I think we've got a few hundred of those up there in Bendigo, so that the results would come to us without us having them. We signed them all prior, so that was a key issue of making it streamlined. The telehealth or clinic appointments there's a vast difference between when we see people who have referred themselves directly to our clinic as opposed to when Elise has seen them. And it's constantly positive feedback about your input, Elise. The women have always had a great amount of knowledge given to them, and so there's not that much left for us to do other than run through the NTOP process. Just a little bit more, but that's already been done, so they're coming pre-armed with a lot of information. Our appointments, therefore, are about 30 minutes, and sometimes we don't really even need that much. So Elise's work makes us better, or look better, and I was just looking through. We have found that there's much less discussion regarding contraception description of process because of Elise's input. It has been, from our perspective, it's been like having another nurse in the clinic. And as you were, and we've thoroughly enjoyed, both Rich and myself, having the collaboration. The key to it all is this just Excel spreadsheet. It's very basic. We share it between us. Elise puts the women in when she sees them, and then we put the results in when they come in. And then when we follow up with the phone calls and the second beta HCG, we put that in also, and then just mark them off as completed. And then any that have slipped through the cracks, I think I was looking through last night, there's been 3 out of the 60 or so who we've lost to follow-up. Our process around that is they get 2 phone calls and 2 SMSs. Then they get a registered mail with a pathology slip, and then we leave them in peace. But they're always welcome to give us a call if they want to re-engage. So I didn't think those stats were too bad. I think it works out to be just under 3%. During COVID, it's been amazing also because telehealth, there was a lot of stuff that we used to do without any sort of ability to keep the wheels greased from a remuneration point of view. And the other aspect was women would have to travel occasionally. So the ones who were too far away and would just do telehealth prior to telehealth item numbers, now we aren't doing that for free, which is great. But also women don't have to come there. We're seeing a few people from make a little bit further away and make it easier for them. So I suppose the spirit of this talk particularly was about collaboration. The cases have been relatively straightforward, most of them. I couldn't see any when I went back over them all, glanced over them, that were too interesting. But the thing which I have found really enjoyable is not just the collaboration with Elise, but also the collaboration with surrounding, particularly friends, fellows, and the women. So a couple of cases sort of reflect that we're not working in a bubble, and that without extra help from outside, with the extra help, we can create a really amazing sort of streamlined service that I think women really enjoyed. So just some quick cases. A G2P1, previous non-vagina delivery. She travelled a long way. She was unsure of dates, but and very anxious and unable to get an ultrasound in a timely fashion. She'd seen, I think she'd come from Echuca, and Elise called us on that day, and we saw her that afternoon. But the pregnancy was about 20 weeks, and she'd had some irregular periods and wasn't really sure, and she'd been quite busy. And thankfully, the team at the Women's had picked her up the following week, and I spoke to her a week or so later, and she was sort of very grateful that she didn't have to go through too much more. There was a bit of conversation, making sure she'd been plugged in and wasn't lost in the mix, but it was very streamlined in the end. Another case was a G2P0, a 45-year-old referred from Ballarat. And I worked with Michael Carter in Kyneton, and it turned out that in the conversation, that first conversation we made just to reassure her that we had got the referral, she'd said that she'd had private health, and a quick text to Michael, and he had her in a couple of days without her having to travel across to, she was after a stop, without her having to travel across to Kyneton to have that. She was able to have it in her hometown. Another case was just last week, actually, a G9 M3 P5+1, and she'd come in from an MTOC, and she thought she was pretty close to 9 weeks. So Elise rang us. We got her in that afternoon. When she arrived, she'd had the bedside ultrasound was 8+5, but she'd had this past history of 1.5, I think, pph with the twins, which, you know, that's not unexpected completely. And then she'd had an undetermined pph with a second last child, and through the discussion she was keen on a tubal ligation. She was only 28, but she was certain that she'd finished her family. Again, Michael Carter came to our assistance, and I just, with the pph history and the desire to have a tubal ligation, I thought in the best hands it would have been, it was for Michael to do when she was going to go under for a general anyway. So she's booked in 2 weeks' time for both the stop and the tubal ligation on the same day at Kyneton Hospital. So that's been fantastic. She was incredibly relieved. So it was a fortuitous conversation. The last one was just the other day from Ballarat, G1 P0, type 1 diabetic. And she was really keen for a surgical termination. I know this is about MTOP particularly, but just family planning in general. I just felt that that might have been a little bit too much for her to be travelling across. She might have been able to get on first on this in Kyneton, but we were able to plug her into Geelong for this coming Friday for a consult, and then stop the following week where she'd be more in a safer place, I suppose, than a little hospital when she's travelling across the country. I suppose the point of all that is that the collaboration is continuous from the first contact with Elise right through to different services around the state. and they've sort of, those services or collaborations downstream from me have just come about through conversation and communication, but it's been fantastic to work in the middle. I have to put a special mention out to the theatre nursing staff at Kyneton, who just bend over backwards, squeeze women in, often just in the morning and during lunch, and without them I wouldn't be able to do any of the work that I've been able to do. And that's, yeah, I think it's been a very positive. I think it could be rolled out across the state. It's very simple. And it's been a very positive experience for us and for the women who we've been looking after. Thank you.
Yeah. Thank you so much to both of you. That was a fantastic presentation, and just shout out to the services involved. That is a fantastic collaboration. While you were talking, the questions were coming thick and fast. People were scribbling them down on the side. So I'm aware of time, and we have another presentation. So is it okay if I do a little summary of the questions and just fire them back at you? First one, Elise, who funds you? Everybody wants you and your model. So who funds you?
Yeah, so we're a not-for-profit organisation, but it's the Department of Health and Human Services that we get health promotion money to fund My Well Women's Clinic.
Because you're quite unusual, aren't you, to be a women's
I'm the only
health,
women's health service that has direct service still going. So we're very lucky, and we want to continue that. So we'd hate to lose the fund.
Was that, Elise, because you, in particular, your group lobbied directly to have that reinstituted?
Yes, we've been doing lots of lobbying, and I've been here 10 years now, so it's always been, you know, that worry we're going to lose funding, but I think just with the numbers of women that we're seeing, and we just have had the support from the community as well, so it's been awesome.
And how long have you been in that position?
So I'm coming up to 10 years in October. So a long time.
Yeah. So,
but I love the work that I do, and I'm not ready to move on yet.
So I don't think you're part of the Hub's funding. Daniel Matza is sending more questions than I can read, but another one of Danielle's questions is, and I think the answer is that you're not part of the Hub. You know, the government funded hubs. No. Yeah. And it is fascinating. I'm not trying to be rude, Danielle, but I'm just trying to summarise all of your questions because they're all really good. And another real thing that came up, and Kath and I were also whispering about it together, is show us the spreadsheet, because we've been trying to develop a spreadsheet for similar things for our telehealth model, and I'm delighted to hear it's easy, Mark, because I fell in a hole with mine. So we're wondering if we could possibly, you know, maybe see what info you record on it, and how what was your platform?
Oh, it was just literally Microsoft Excel, and I'm just trying to get into my Excel account on this computer. I'm on a different computer than usually, and I'll be able to get it up on my iPad. And so what you do is we just shared it with Elise and Richard, and so everybody can edit it at any particular time. And I mean, it's a what do you call it? A secure site. Microsoft security is what we're using for.
But you've got three users.
You could have as many, you could have as many as you needed. And just across the top, we've just got, you know, the patients, the date that we see them, the name, the date of birth, the EDD, where the counselling was done, the ultrasound where it was done, and the EDD where the ultrasound was done. The first beta HCG, the blood group, anti-D, STI and BV screening, the type of contraception that has been offered, and then hopefully given, And then we have 2 streams, but mainly MTOP, and then the date that they were seen for the MTOP, the consent process that it was done, if the MIFI, when the MIFI or if it was supplied, MISO was supplied, and then it's a bit of double up there. It's a bit, we need to sort of fine tune it, but the first beta HCG next to the second beta HCG, and then the phone call when it's booked in for. And then once we've completed the second beta HCG and we've called them, we just put at the beginning of it all completed. So you can see that on the first sort of slide. And then there's a surgical termination section as well, which is more for my records of when the hospital's been contacted and emailed and date of the procedure and how many weeks they are at that point.
Mark, it's Kathy. I'm just wondering if you wouldn't mind sending across those headings, just do it, cut and paste to the headings, and I'll put them in the practice notes from this meeting so everyone's got a copy of it.
So summarise it in a de-identified way. One last question from, and I'm aware I'm not asking all of the questions, but one last question was, do you do remote STD screening as well? So I presume sometimes, Elise, you're sending the patients back to their local community to have STD.
So that just works as a normal like telehealth or phone call consult. So it's a detailed sexual and reproductive health consult. And because I've got Mark's pathology, I can write up the STI screening as well. And I've done further training in that to be able to provide that as well. So HIV, Hep B, Hep C as well. So, and we just use that shared care live database for that as well. So he can see the women that I've seen and written them up for STI screening. And I usually just send him a message so that he is aware of them and they're not just sitting there with all the other women that are wanting an MTOP, so he knows that that is specifically for an STI screen.
Right, we'll send
that works well.
Yeah, we'll send all of those summary points through. Look, thank you both so much, and I'm just hoping we can squeeze in Katie Snow from Bendigo Community Health. Are you with us still, Katie?
Yep. Hi, everyone. And I haven't made anything formal, so I'll just be quick. But Louise asked me if I could just have a bit of a chat about how we've been managing termination services in the time of COVID. And I'm in a fun, slightly unique position here. I'm a GP registrar in my final term, and I only joined the sexual health team and became an MS2 step prescriber in February.
Oh, wow. Good on you, Katie.
So I'd actually only been prescribing for about 2 months before the shutdown started. So I've got a great sort of before and after. And while demand, you know, ebbs and flows, as you all know, our numbers, in my first 2 weeks, I'd prescribed 10 times and then I stopped counting. So I'd had a fair bit of experience and exposure before we went to the shutdown. So when the writing was on the wall and the central site was going to be closed and I was going to have to be working from home, and also I've had 2 COVID swabs so far, so I was both negative, thankfully, but I was very aware of the possibility that it might not be the woman who can't come in, it might be me who can't come in. I started making some plans for how to continue providing the service. And we've got a list of the pharmacies in town that stock MS2 step, and there's 3 or 4. One of them is actually a 24-hour pharmacy in the centre of town, so easy to access. So I called them, spoke to one of the pharmacists and was like, look, are you able to help me do this remotely? And women are largely still coming in and having their initial consult with one of our 3 nurses, including Louise. And then for most women, I'm seeing them in a similar model to what Elise and Mark have. I'm seeing them after most of the legwork has already been done. But sometimes they don't tell our receptionists what they're calling for, so sometimes I'm actually seeing them as the first point of contact as well. And so we're having some women who are remote and pretty much exclusively over the phone. We've got telehealth services. Most people aren't taking us up on them. From this first contact with us, right through until our follow-up appointments. And it's actually been working really well. So we're fortunate in Bendigo, we haven't had any issues in lack of access to ultrasound scans. So women have been able to get them in a timely fashion and still get the bloods done. Most of our referrals come from GPs in the surrounding area. And most, I don't know, Louise, quite what the stats are, but certainly from my experience, it would be probably 95% MTOPs. And I don't actually do that many referrals for stops. So my process has been doing it over the phone, and I haven't had too many cases where assessing sort of consent and lack of reproductive coercion has actually been a problem. Most of the time, a couple of questions. I start off by saying, are you by yourself right now? And some of them will say, but most of them say yes. Some of them actually have their partner there, and they'll put me on speakerphone, and so I can hear the way the partner's engaging. But most of the time I'm talking to a woman, and she says at least that she's by herself, and I've got nothing in the tone of voice or response to questions that suggest that there's actually anything to be concerned about there. Now, one of the big issues we had was, how do we get everything to the woman? And one of the first, the other significant parts of that is, how do we get a written consent form? So when I spoke to the UFS pharmacy that was going to help us out, I asked them if I was able to email them everything I would normally hand to the patient in the room, and they agreed to print it out for the woman. So not only the scripts, they're printing out the pathology form, the instructions on how to take the medication, the letter to the emergency department that we give all the women, and also the consent form. So what I'm doing with consent is that I am reading the Murray Stopes consent form verbatim to a woman and giving her options to, opportunities to ask questions. Now, and if they're happy to proceed, I'll prescribe for them. And I've got a set email, because this pharmacy has over 20 different pharmacists. And so I've got a copy and paste email that I send everything to the pharmacy to, asking the pharmacist if they're comfortable to give the form to the woman, ask the woman to sign it, and then send it back to me. So I'm getting verbal consent at the time that a woman has understood the consent form as I've read it out to her. And then I'm also getting the written consent form coming back within a few days' time into our inbox. So it's nice that we're still getting that more sort of legal documentation. We're doing most of the STI stuff remotely, unless they've actually seen one of the nurses, in which case they're done on the day. And I'm just emailing patients who have access to a printer. We're emailing them the pathology forms. If the patient doesn't have access to a printer and they live locally, then they're just coming into the Eaglehawk Clinic to pick them up. I am working on site 2 days a week, even though on even my on-site days I'm doing a lot of telehealth. So where there's been a patient where it hasn't been ideal to do it over the phone, I still had the flexibility to see them face to face. And the main one where we had to do that was a refugee Karen speaking patient who did not want to use an interpreter and wanted her boyfriend to interpret for her. So very, very difficult to assess things over the phone in that situation. So I actually got them to come in and could assess more thoroughly in the room. Aided a little bit in that situation in the fact that she'd actually had an MTOP last year as well. So she already kind of knew a little bit more of what she was in for. But it's been going pretty well overall. And very much big thanks to Louise and our other two sexual health nurses, Bosca and Beck, who are doing most of the face-to-face legwork for the initial consult, making it a lot easier for me to be doing most of it, the rest of it over the phone. Now, I did have one slightly interesting, challenging one to mention, who was a 14-year-old in Maryborough, who was referred via the Ballarat Emergency Department for a termination, and the reason that she came via the emergency department is she had presented there with an intentional paracetamol overdose. Non-lethal, fine from that regards, but in my initial consult with her, I was put on speakerphone, and in the room was the patient, the mum and the grandma. And as much as you can from a 14-year-old who may be relatively reticent at best of times, she did say that she wanted mum and grandma to stay there, and she was very adamant that she did not want to continue the pregnancy. And while it's hard with a 14-year-old to assess whether or not there's any coercion going on there, I took the vehemence of her response as being sort of a key there, but also the fact that she'd presented to us after having found out she was pregnant and responded to that by having a paracetamol overdose. And this is someone where having follow-up and being able to do sort of mental health and concerns of sort of the ongoing care there would be really important. Really hard to do when she lives a while away, doesn't want to come into Bendigo, 14. But after having presented to the emergency department, she was going to be followed up by CAMS. And then we later found out through some additional phone calls that were made to Louise that she was actually being followed up by Socket as well. So the fact that those additional services were already going to be involved and going to be actively following her up made me a lot more comfortable to just be able to stick with my part of the role and trust the rest of the system to make sure that she was followed up in other regards. And she did follow up for her follow-up appointments, and and we could discuss contraception, and she's going to see her local GP for an implant on.
Thank you very much, Katie. And again, your presentation and your history really emphasises that collegiality and teamwork and on referring. Sometimes we feel like we have to sort everything, but sometimes it's sharing the load. There's another really interesting theme that's developed, which is the getting of consents, but we've run out of time for that, and possibly that might be another sub-issue for another date as to what legal requirements on us to get a written consent in these telemedicine days, and how we can share the different models. The other theme that came out is that every locality has its own model, and it's based on your local relationships. And that's the really overwhelming message that I get, is that there's no one size fits all. And this is a really great example of that. We're going to close. I was hoping to have a few minutes for questions. If anyone else has got a final burning question, Kath and I will commit to summarising all the various links that people have shared, the articles they've shared. Mark shared the titles on the spreadsheet. We'll summarise all of that and share it together with, for some of you that might not already know, the updated guidelines with regard to anti-D and the relaxation of testing for rhesus status and prescribing anti-D in early medical abortion as mandated by the college. So we'll give you that as well. Is there anything else anyone wanted to add at this stage?
No, just with that case, I was just wondering why they rang to Bendigo when I just wondered if there was no providers closer to her.
Now, I'm not sure. I think geographically we are slightly closer to Maryborough than Ballarat. I did think that was slightly odd
yes.
at the time, and I never actually asked why. I don't know if she, because normally from Maryborough they would come to the Bendigo Emergency Department, not Ballarat.
Oh, okay.
So I'm not quite sure why she'd gone to Ballarat in the first instance, but yeah, it's definitely a good question. I don't have the answer.
Yeah, that's fine. Thanks.
Patty, I just wanted to let everyone know that we're scheduled to send out another clinical network newsletter in the next little while. So we will make sure that the case studies and the notes from this meeting, as well as the link to the recording, is all on there, and I'll put the resources that have been mentioned by Danielle and others on there as well. And if anyone wants to contribute to that, please let us know.
Yeah. That'll be really useful. And I just use the closing words from me is that this network, this platform is just going from strength to strength. The amount of experience in the, I was going to say in the room, the amount of experience in the virtual room here is really phenomenal. And there's a lot of really great stuff going on. So I can't thank you all enough, and we'll look forward to being in contact again.
Thanks a lot, Patty.
Bye for now.
Thanks.